Okay. So, welcome everyone. Thank you for joining Dr. Bush and I tonight for this webinar on Is Your Bone Scan Telling the Whole Story? For those of you who don't know me, my name is Susan Brady. I'm the founder of Nurtured Bones. I am a physical therapist with over 35 years of experience, as well as an integrative health and nutrition practitioner. And my practice is focused on helping women and men with osteoporosis take a more holistic, informed approach to building strong, healthy bones. Now, I first met Dr. Bush. Hang on, let me admit some more people. I first met Dr. Bush about 4 years ago when I became curious about REMS technology and Echolight scanning, and I actually traveled down to North Carolina myself to have a scan done, and I was impressed not only by the technology but by Dr. Bush's depth of knowledge and his truly thoughtful, patient-centered approach. And since then, I've been working closely with him to bring REM scans to women and men who want a deeper understanding of their bone health beyond that single T score that we get on a DXA scan report. So I am really looking forward to tonight's conversation, and I'm excited to introduce Dr. Bush. Let me admit. Okay. So Dr. Bush is a board certified orthopedic surgeon with over 30 years of clinical experience. He completed his orthopedic training at the University of Medicine and Dentistry, University Hospital in Newark, New Jersey. And he was in private practice in central North Carolina for about 2 decades. In the most recent years, he has shifted his focus from surgical fracture fixation to proactive fracture prevention. As a member of the International Society of Clinical Densitometry and as trained in DEXA scan interpretation, he recognized the transformative potential of REMS technology, and REMS stands for radiofrequency echographic multispectrometry. And he was one of the earliest adopters of REMS in the United States and has become the most experienced clinical REMS provider in the country. And his practice is now the largest clinical REMS based bone health practice in the United States. And Dr. Bush champions a preventative, lifestyle based approach to bone health. He emphasizes a balanced diet, regular muscle strengthening exercises, healthy lifestyle habits, combined with routine bone scan screenings. And his prescription for strong bones and reduced fracture risk centers on utilizing advanced REMS technology alongside of proactive wellness strategies. So tonight's webinar is going to flow like this. Dr. Bush will start by introducing REMS technology, explaining why it offers important advantages beyond a traditional DEXA scan. And once he has laid out that foundation, we're going to move into questions. Now, I've gathered close to 30 questions that many of you submitted ahead of time. So we're going to begin there since they cover most of the most common concerns women have. And then after that, if time allows, we'll open it up for any additional questions you would like to ask. So with that, I'm going to turn things over to Dr. Bush.
Okay, Susan. Well, thank you. I really appreciate you doing this, Susan. This is a wonderful forum for ladies to learn more about what's going on in bone health. As Susan had said, she had come down to get her EMS. We spoke afterwards. We obviously hit it off. We are on the same page. She comes with that background where she's looking at the whole person as far as dealing with bone health or any other aspect. And I looked at patients the same way in orthopedics, and obviously as I started doing bone health, that was important for me. And what REMS brings to the table is it's a tool that's used in the program that like Susan has set up. So really, the foundation is a healthy lifestyle, is exercise, is eating right. REMS provides the tool to see, okay, where are you as far as what your bone is? So again, working together, I think we have a great program going because both you have the technology, the cutting edge technology, but you also have a solid basis of maintaining not only healthy bone, but your general health. So again, I'd like to thank Susan for doing that. She has a great program going on right now. Now to get into REMS, Susan had mentioned that what REMS stands for is radio frequency echographic multispectrometry. It's a mouthful, but to break it down, what it really means, radio frequency is just a fancy name for sound waves. You're just calling, instead of saying sound waves, you're using the word radio frequency. Echographic means that the sound wave that's being analyzed is the echo. It's the reflection of the sound wave coming back. The older forms of ultrasound use transmission, where they would have an amplifier on one side, they would have a receiver on the other side, and the sound wave would go through the object. That's the old way of doing ultrasound. The newer way is you pulse the sound wave hits the object you want it to hit, and then it comes back to you. And the echo carries information. So that's where echographic comes from. It's this newer form of collecting sound waves. And then multispectrometry is just a fancy way of saying a computer analyzes that sound wave. So it's sound waves that are echographic being analyzed by a computer. That's what REM stands for. Um, so what is it in detail? Let me go a little bit into DXA to kind of contrast it. I think that's going to be very important. So DXA, which has been the mainstay of bone assessment for about 30 years, is based on a very simple principle, is how well do you block an X-ray beam? You're put on the table, an X-ray machine passes underneath you. It's irradiating you. It's passing radiation through you. There's a receiver sitting over you, and the computer knows how much radiation it's making, how much it's collecting, and that difference is how well you're blocking that X-ray beam, and that's that difference. And it has a fancy name called attenuation differential. That attenuation differential, or the amount of radiation that's being blocked, is then converted into a bone mineral density value and then into a T-score. So, but that's all the DEX is doing. You're on the machine blocking an X-ray beam. And many issues come up with that. First of all, the machine doesn't know what's blocking the X-ray beam. It's making the assumption because has the highest density compared to fat or muscle or other things in your body, it's going to block the X-ray beams the best. And then bone that's more dense will block X-ray beams better than bone that's less dense. So that's the whole idea about measuring your bone density. Is if you are blocking X-ray beams really well, well, you must be dense. If you're not blocking them so well, you're not as dense. But you can have bone spurs, which are dense bone and they're not structural. They don't make your bone any stronger, but they will block X-ray beams really well. If you have metal in your body, well, the metal will block the X-ray beams very well, but that's obviously not making your bone any stronger. So DEXA is prone to having errors because it doesn't discriminate what's blocking the X-ray beam. All it knows is the X-ray beam is being blocked. And some of the ladies who know me, I kid around and say, well, I could put a brick on your belly and we could do a DEXA. And DEXA would say you're as thick as a brick because it doesn't know it's a brick. All it knows is the X-ray beams are being blocked. Now it's up to the examiner to look at the screen and say, hey, get that brick off of there. Now, all kidding aside, if you have a piece of jewelry in place, a belly button ring, or you have a zipper or some other metal that falls into the field, or you have metal in your back, well, again, the DEXA is not going to know the difference. It's going to go ahead and give you a result. The same problem arises where positioning is so important because there are equations that are used to take away error because obviously the machine is going through a lot of things that will block X-ray beams also, and those have to be subtracted out by error equations. Well, those equations only work if you're positioned correctly. Your spine has to be straight, your hips have to be in a certain place. If they are not, then the ability of those equations to standardize results, to give you results that are acceptable within statistical standards, no longer holds because either you're crooked or your spine is crooked because you have some scoliosis, you have some curvature, and all that will adversely affect DEXA. So DEXA is known to have problems, and the statistics that are out there, the statistics that are published by the folks who do DEXA, who use DEXA, is that 50% of ladies who fracture, 50% of ladies who sustain fragility fractures, do not have osteoporosis. They either have normal density or osteopenia. So half of all ladies who break do not have the diagnosis of osteoporosis, which is a really high error rate. because you're told if you have osteoporosis, then you're frail. If you don't have osteoporosis, well, then you don't have to worry. Well, in this scenario, everybody has to worry because 50% of ladies who break don't have osteoporosis. 50% of ladies who break have osteoporosis. Um, and that obviously then leads to people being put on meds when they don't need to, or people not being treated or not being told that they should be doing things because their scans might be falsely better than they really are. Most scans tend to be over-predict fracture risk with DXA. Now, REMS is very different. REMS uses ultrasound, so the physics of how REMS is done is very different. We're pulsing a sound wave into you. That sound wave that we pulse, some of it will go right through you and hit the table. We don't care about that. We want the sound waves that hit objects in your body, obviously your bone, and come back to us. So that's the echographic. We want to capture the echo. We want to capture the reflection of the sound that's coming out of you. And multiple studies in multiple universities have shown that if that the quality of the bone that reflects the sound will give a different echo. So if you have good quality bone, the echo coming out of that is very different than the echo that's coming out of lousy bone. And Susan, I'm going to share my screen because I have a nice slide to show that. Um, so I'm going to make this something. Susan, you can see the screen. I mean, I think everyone can see that.
Yep.
Let's share
Hmm.
it. Okay.
Yep.
So this is out of a study where they took bone of different quality. So the three samples of bone on the left-hand side, you go from lousy bone from incompetent bone, not strong bone. If you notice the word, I'm not saying osteoporotic. It's incompetent bone. The second one going down is not as bad, and the bottom one is good bone. So you have good bone, mediocre bone, lousy bone. And then the sound wave that's to the right side, those are the echoes coming out, and you can see that the echoes are different. So when a sound wave interacts with a bone that's good quality, you get a certain sound wave. When you get a sound wave that interacts with bone that's lousy, you get a different sound wave. And this is the basis of REMS. So with that knowledge, what we're doing is we're harvesting the sound wave, and then that sound wave gets analyzed. What is it? Is it coming out of good bone? Is it coming out of lousy bone? So there's a few steps in between. I'll go into a little bit more detail with that. So one of the aspects of REMS that's really important is that first, the sound wave that we're capturing is filtered because the sound waves that come out of you, we're not just getting bone, we're getting muscle, we're getting fat, we're getting intestine, we're getting kidney, we're getting everything. We're getting bone spurs, if you have metal in your back, the metal will be reflecting sound. So we're getting all of these sound waves coming back to us as that echo. And the best way to think of it is if you think about yelling into a canyon. Now, your friend will hear you on the other side of the canyon, but you'll get an echo that comes back to you because some of your voice will not make it through the canyon. It will hit things. It hit the walls of the canyon, it hit trees, it hit something else, and it'll bounce back to you. So you'll hear an echo. It'll repeat what you say, but it won't sound like you because the canyon changed your voice. And what changes your voice? Well, everything in the canyon, whatever it bounced off of. Well, that's happening in REMs. So the sound waves that are coming back out of you are carrying that information, I just showed you because you have changed that sound wave. Now, with sound waves, you can actually break them apart. You can take a complex sound wave, a complex echo that's coming out of you, and you can unravel it into the individual sound waves that make it up. So it's a complex mathematical process, but it's done in every music studio. If a band records a song, an amplifier is humming. Well, you don't have to bring the band back. You can take the song, you can unravel it, you can find the different peaks in the sound waves. You find the amplifier that's humming, you get rid of it, you put the sound back together, the sound waves back together, and you got a clean song. Well, REMS is the first step of that. It unravels the sound wave. And then the developers of Echolight, and I'll say the Italians, they're the ones who developed Echolight. So the Italians have set up a database of sounds, of a sonographic profile of structural bone. So you have a database of sound waves that are coming from structural bone. And each one of your sound waves is compared to that. And if it matches, it goes in the queue. If it doesn't match, it gets kicked out. So bone spurs are bone, but they're not structural. They don't match, the sound waves don't match. They get kicked out. So REMS doesn't get fooled by arthritis. If you have a broken bone, well, that's not structural. It doesn't match what's in the database. It gets kicked out. Muscle, fat, intestine, kidney, liver, all that gets kicked out. Metal gets kicked out because it doesn't match structural bone. The only information that goes in the queue are the sound waves that match the database. if the queue is filled, and it's called a signal to noise ratio. If that threshold is met, if there's enough signal that it's a pure signal, not noise, the AI will move on. It'll process it. If not, it'll make me do the test over again. So right off the bat, that's the biggest difference between REMS and DXA. The error rate in REMS is much, much less because it's going through all these steps of filtering and searching for that sound wave. And again, the AI, it's smart, but it's not, it's as smart as the people who programmed it. And what they've programmed into it is this is a threshold you need. If you don't meet the threshold, doesn't care how nice I am to the machine, it makes me do it over again. And again, some of you who might have had me examine you, sometimes it's 5, 6 times before I can get what the AI is happy with. And it's a pain in the neck, but it's a good pain in the neck because you're not going to get a bad result from REMS. At worst, you won't get anything. So that's really right off the bat, big difference between REMS and DEXA. Now, that information that I just kind of showed you that slide where you have that sound wave coming out of you and we've harvested it and it's carrying this information on your bone. And we know that from these studies. I want to take a step a little bit outside of this to show you really how much information is coming out of you. And again, kind of go into a field that's really not spoken very much about ramps, but really what the future is. So I'm going to share my screen again, and I want to show you a study that the developers of Echolight, the Italians, did about a decade ago. So what you see on this slide is the proximal femur, is the hip. And the reason I'm showing you this slide is what the Italians decided they wanted to do something with a bone that was not just cut out of a cadaver bone, just a cube of bone. They wanted a bone that really came out of the body. And the best bone to use is a hip, because when somebody has a hip replacement, what we do is we cut off the ball and we throw it out and we put the hip prosthesis in. So they grabbed that ball, and you can see that right over here. This is the head of the femur that was removed during a hip replacement, and they took that to the laboratory. And it still had cartilage on it. It had some bone spurs. It had some tendons still attached. So they took it in situ, the way it was removed in the operating room, and they analyzed it. And they first analyzed it with a CAT scan. So they put it on a stick and they hit it with CAT scan, and the CAT scan will slice through objects. It'll give you a series of X-rays. And because the femoral head is round, it's a ball, your X-rays are going to be circular. So they're going to look like these. And this is the center cut through that head. It's the largest diameter circle. And if you look at it, it looks like a pizza. The cortical bone, the hard bone on the outside is your crust, and the woven bone, the trabecular bone that we want to know about is the cheese and the sauce. Well, whoever made that pizza didn't put the cheese on evenly. You can see that these are the slices you want, but you want to leave these slices alone. Well, the bone is not distributed evenly. So the bone is you have stronger bone here, you have weaker bone there. Well, the CAT scan can actually measure that. So they sliced up the pizza into 30 slices, and they had the CAT scan measure bone versus space, white versus black, cheese versus sauce on every slice. And the ratio was better here, was the higher ratio here and the lower ratio there, meaning better bone is here, worse bone is here, a little better bone is there, but still the best bone is right here. Well, they put those numbers on the graph. Now they repeated this experiment with ultrasound. So they took every slice and they hit it with a sound wave. And remember, this portion of the sound wave that comes out, this is the portion that varies depending on the quality of the bone here. So every slice would generate its own sound wave. Those were put on the graph. And when you look at the graphs, they're identical. So when you get a REMS done, you're getting an analysis of your bone at the level of a CAT scan without the radiation. We're not blocking X-ray beams. We're not just seeing how well you can block an X-ray beam. And that's been going on for 30 years. That hasn't changed. 30 years ago, we didn't have iPhones. So this is cutting edge technology. Now, what is this? I mean, what are we looking at? Yeah, we're looking at a representation of your structure, but what is the structure of your bone? Well, the structure of your bone, and obviously I have a slide for that, and it's a very complex slide. And this is not even doing its service. You can add an easy dozen boxes to this. So this is bone strength or bone structure, because bone structure and strength really are interchangeable. The structure determines strength. The two arms on the side, on the left-hand side, those are macroscopic. We can ignore those. The rest of these boxes are all microscopic properties. All of these are being measured by REMS. Each one of these produces its own sound wave. Because the sound wave bouncing off of collagen is different than the sound wave bouncing off of crystal, is different than the sound wave bouncing off of mineral. So all of this is information that's in the REMS right now that we are getting, that I'm getting when I do a REMS on you. The problem, though, is we can't break it down into this yet. The technology, the ability to actually parse out the collagen, to parse out the mineral is not there yet. It's the research work is happening. That's why I know this is happening because that slide I showed you earlier, it's only one of the sound waves in the bone sound wave. It's the one that shows you trabecular bone. But this is the kind of information that's coming out in REMS. Again, we're not just blocking X-rays. We are getting this information out of you. And it's at some point in the future, we'll be able to use that to interpret it. But what happened, what the Italians decided to do, since we can't break it apart yet, and use that to give you information on your collagen or on your crystal yet, what they said is, okay, we have this information and we know it's the structure of your bone. Now I'm going to go to a slide to kind of just show you what the sound wave that comes out of you looks like when we do a REMS. This is just a representation, or this is the sound wave that comes out of you. And it contains all of that information on that slide that we just saw. It contains the collagen, it contains the crystal, it contains the mineral. All that information's in there. Again, we can't pull it apart yet and use it clinically. We don't have it's not clinically validated yet. But what the Italians said is, okay, we know all that information's in here. We also know that strong bone doesn't break and weak bone breaks. And that's the big difference with when you speak the language of REMS versus speaking the language of DXA. In DXA, you're talking density. In REMS, you're actually talking bone structure. And you're talking the way an engineer speaks. Because if you want to know whether a building is going to fall down or if a wing's going to fall off an airplane, you don't measure density. You measure structure. You look for cracks. You look for metal failure. You look for cracks in the foundation. You look for termite damage. You look for water damage. You're looking for anything that's going to weaken the structure of the building to determine whether or not it's safe to be in. So the only people who use density to determine whether a structure is going to fail are doctors. There is no engineer who does that. The engineers are looking at structure because a strong building will stand, a weak building will fall. A strong skeleton won't break, a weak skeleton will. So the Italians know strong bone doesn't break, weak bone breaks. So this signal that's coming out of the person being examined, it's carrying the information on your bone, and we need to determine, is it coming from strong bone or is it coming from weak bone? Well, how do you do that? Well, you have to compare it to something. You want to compare it to strong bone, you want to compare it to weak bone. Well, you develop a database of strong bone. You have people who haven't broken, and you have the sound waves done, and you have an average sound wave of strong bone. Then you want weak. You want weak bone. So what's weak bone? Well, people who have broken. You get their sound waves, and you have an average sound wave of weak bone. So in this graph, all the way to the right-hand side, you have the red line is the sound wave of coming out of weak bone, and the green line is the sound wave coming out of strong bone. And they're statistically very different. Now, when we do your REMS, I hold a probe over you, and I am pulsing a sound with a sound wave into you, and the echo is coming back. Well, also what I'm doing is I'm slicing up like a loaf of bread. That probe has rows of zirconium oxide crystals, and the crystals, each row will sequentially pulse and listen. So it's slicing you up like if you take a loaf of bread to your to the grocery market and you have them slice it up for you. That's what I'm doing to you. And this is a representation. The picture on the left is a representation of how you're getting sliced up. Each one of those slices, each one of those segments of sound wave will generate its own sound wave, which then gets compared to the sound wave coming from somebody who has fractured and who hasn't fractured. And then it's assessed whether it's fragile, meaning it better matches the person who fractured, or it's non-fragile because it better matches the one who hasn't fractured. So with REMS, you get a fragility score. You have a number which represents the number of slices of your bone that better matches somebody who has fractured. So in this case, this person has a fragility score of 23. Well, is that good or bad? Well, right off the bat, you can do the math. Now it's out of 100. So there's more than 100 rows of crystals, but they use 100 to keep it simple. So 23 out of 100 sound waves match somebody who has fractured. Well, that means 77 slices better match somebody who has not fractured. So the majority of bone is strong. Now, to determine fracture risk, since we're using statistics, we have to also use the statistics of fracture risk. So the graph you're looking at is a graph on the second page of the REMS report. And this is your fracture risk assessment. This is determining whether you break or not, or how you assess whether you break based on your fragility score. So this graph is actually representing 10,000 plus people. It's a database of 10,000 plus people. When I bought my machine 4 years ago or so, 4 or 5 years ago, it was 10,000. Now it's somewhere between 10 and 20,000. So it's a robust database. And this graph was made by having people come in, getting a REM study, getting a fragility score. And if they have not fractured, their score is put with a green dot. If they have broken, their score is put with a red dot. So these are thousands of red dots and these are thousands of green dots. Now, what's the yellow? You either break or you don't break. Well, the yellow is an add-on color. It's a ribbon covering up where the green and red overlap. So within the red zone here, there is no green. It's all red. It's an absolute. Everyone has fractured in this region. The green zone is an absolute where no one has broken. There's no red in it. Now, the yellow, if you peel it away, if you're by the green, you will see a sea of green dots with one or two red ones, indicating the majority of people haven't broken, but a few have. If you're up by the red, it's exactly opposite. You pull the yellow ribbon down, you'll see mainly red dots with a couple of green ones. The majority of people have broken. If you're halfway up in the yellow, even number of people have broken and haven't broken with your score. So you're going from strong bone to weak bone, and the transition is happening in the yellow. As you go up in the yellow, as you get closer to the red, fracture risk increases. Um, I don't know if this is a good place to take a break, Susan, or just for questions, or if I mean, there's actually one more thing I do want to go over, but we can also save it for a little later. If again, maybe it's time because I just gave, I mean, I think I gave a ton of information just now, so it might be good for people to process it. And again, if they have questions or you have questions that might be relevant to this, we can take a little bit of a break then.
Well, I can certainly move forward with some of the questions because I think it'll help to take the information that you just gave us and put it into kind of layman's terms in real life
Yeah.
situations.
Okay.
Okay. All right. So, um, question one, why does a DXA scan, what does a DXA scan measure? And you've already covered that. It measures density. And what important information does it miss that REMS can provide? And I know that you just kind of covered that a little bit, but maybe just compacting that information to answer this question.
That's a very good question. I think and also it's a perfect timing for that question. So the DXA does just measure density, and I had mentioned that the engineering world does not use density to determine if a structure is going to fail. And let me give a hypothetical, but this is kind of an everyday example of that, of what I mean by that. So I used to use chalk and a pencil. I think that's still good, but this is, I think, a little simpler to think about. If you have a glass rod and you have a plastic rod, an acrylic rod, and they look the same. They're both translucent. You can see right through them. Now, they weigh the same. They have the same shape. They weigh the same. You put them in water and they displace the same amount of water, so they have the same volume. So density is weight over volume. So that the glass rod and the acrylic rod in our example have the exact same density. Drop them. Plastic bounces, glass shatters. But they had the same density. So obviously, density would not determine whether they're going to break. What determines whether they're going to break? It's their structure. The plastic is a polymer. It's these long chains of molecules that are interwoven together, which are resistant to fracturing. Whereas glass are crystals packed together in such a way that if you hit them or they drop, they shatter, they're brittle. So the determinant of whether the rod was going to break was the material it was made out of, is the structure of the material that it's made out of. It's not the density, because they have the exact same density. So REMS gives you a measure of the structure of your bone. The sound wave coming out is coming out of a bone that's either weak or strong. And then you were using the comparison to figure out, is that sound wave coming out of strong bone or weak bone? If it's coming out of weak bone, your fracture risk will be higher. If it's coming out of strong bone, your fracture risk is going to be lower.
So I think that a lot of what you just explained goes into answering the second question is why can two women with the same T-score on a DXA scan have very different fracture risk?
Because it's the structure of the bone and the density, the way the density is measured, it's not, there's also statistics to come into that. But you're measuring density, and density is not a reliable way of determining fracture risk. I think the chalk and the pencil example that I use may be better because I base that on T-scores. So if you think of a piece of chalk, the kind that we used to use when we were kids in grammar school, very dense. Um, it'll block an X-ray beam really well. Now you cannot do a REMS on a piece of chalk. The sound wave coming out of chalk is not structural bone. REMS will never give you a result. But you can do a DXA on a piece of chalk. So you put that on a DXA machine, and the chalk will block the X-ray beams really well. The X-ray beams will not go through the chalk. So the chalk is going to have a high bone mineral density. It's going to have a fantastic T-score, way up in the green. The doctor's going to be proud of the chalk. It's going to pat it on the head. Everything's great. The pencil is wood. X-ray burns right through it. Wood does not stop X-ray beams. You're going to have a horrible T-score. You're going to be way down in the red. You're going to have to go on medication immediately because you're going to break. Well, before we start the medicine on the poor pencil, let's drop them. Based on the T-scores, the chalk is supposed to bounce because it's in the green. The pencil is supposed to shatter because it's in the red. Well, what happens in reality? Exactly opposite. Um, so again, let me just I actually have slides for that. Let me just kind of show that quickly. So your chalk would be way up in the green, fantastic T-score. Your pencil, it should be even further down in the red, horrible T-score. But when you drop them, what happens? The chalk shatters, the pencil bounces. The T-score did not determine which one was going to fracture. It did not do it reliably because the density alone, the chalk is very dense, but it's not strong. The pencil's not very dense, but it's strong. We build houses out of pencils. We build houses out of wood. We don't build houses out of chalk, even though wood's not dense. It's strong. And again, that's where the engineering comes in. You need to think like an engineer. Is this material structurally strong? Not is it dense? Is it structurally strong? And if you have strong bone, you're not going to break. You could have dense bone and you could break. Paget's disease, I just want to bring another name. You can have other diseases that make your bone very dense, very brittle, high tendency of breaking. So density is not the property that should be measured. It's been measured for 30 years because that's the only property that could be measured. With new technology, with new abilities, yeah, we should be looking at structure. And the people who do DEXA realize that. That's why they're promoting TBS. I think some of you might have heard trabecular bone score. That's the DEXA people trying to get into the realm of structure, using DEXA to try to assess the structure of the bone because they realize density is not a reliable way of determining fracture risk.
So I got a lot of questions on the fact that when somebody's had a DEXA and as well as a REMS, their T-scores are very different. How should those differences be interpreted, and which one do you believe?
Okay, so I'm a REMS guy and I'm a structural guy. I'm an orthopedic surgeon. I call myself a bone engineer. So I call the endocrinologists bone philosophers. So the philosophers and the engineers look at the world very differently. I look at structure, and for me, we shouldn't even bother with T-scores. They really are, they're not reliable. But since we are in a world of T-scores right now, the main reason, I mean, this is, again, this is how crazy bone health is. So to convert bone mineral density to T-scores, what you're doing is you're comparing. You have to set up a benchmark because you get a bone mineral density. Either REMS will give you a BMD, DEXA will give you a BMD. Now, so it's a number. Well, what do you do with that number? Is it good or not? Well, you have to compare it to something. So the comparison that's used by convention is the average BMD of a database of 20 to 29-year-old white females. So if you're between menopause and 90, or if you're a guy between 50 and 90, by convention, we're being compared to a bunch of 30-year-olds. And that comparison is then done statistically, which generates a T-score, which is how far you are away from that benchmark bone mineral density value. If you happen to be exactly what the 30-year-olds are, if your bone mineral density matches the 30-year-olds, your T-score is going to be zero, meaning you're right. It's determined by a bell curve, by a population distribution. The middle of the bell's cut in half with the average BMD of the 30-year-olds, and then we see how far away you are from there. So if you happen to match them, your T-score is zero. If you're better than 30-year-olds, your T-score will be positive. Well, again, probably most of us here are not 30 anymore. We're older. Statistically, we're going to be going negative. So the determination of that T-score then again is based on this database of 30-year-olds. Now, REMS uses the database from the CDC. It uses the NHANES database. So Echolight chose to use NHANES 3 database for the spine and the hips to convert bone mineral density to T-scores. Hologic, which is a company that makes DXA machines, has a proprietary database for their spine, and they use the NHANES 3, the CDC database for their hips. GE, which is another manufacturer of DXA machines, has a proprietary database for the spine, and it uses the CDC database, the NHANES 3 database for the hips. So you can't compare any of those three because it's three separate databases. So it's not only you can't compare DXA to REMS, you can't compare Hologic to GE because they're different databases. They're off by at least 10%. So right off the bat, you're comparing the spine bone mineral densities from two different databases. So that's first one of the reasons why there's a difference a lot of times. The other thing, it's two different physics. I mean, you have the physics of radiation and you have the physics of sound. You're going to probably have differences because of that. Um, Also, something that I see commonly, and again, some of you ladies who might have had DEXA and REMS might also see this. It's the DEXA spine that's off in left field. So the DEXA spine and the DEXA hips will be what's called discordant. They'll be separated by greater than the standard deviation. But when you look at the REMS spine and the REMS hips are within the standard deviation. They're concordant. And then the DEXA hips are matching the REMS hips and REMS spine. So the one value that's wacky is the DEXA spine value. So that's the pattern we see. But unfortunately, you really can't compare them because they're all coming from different databases. So I know that's I kind of a long-winded answer, but I think that's the best answer for that question. And
And
as a REMS user, as a guy who as a doc who uses structure, I kind of laugh at that. I say that's why I don't use T scores because they're unreliable and it's kind almost comical with the craziness of trying to make sense out of it when it doesn't make sense because really it's not a reliable way of determining whether you're going to break or not. It's not determining the structure of your bone. It's one physical property of bone and that's it. And the way it's being measured is different in different using the different methods. Oh, sorry.
no, but on the same line as seeing such differences, especially in the T-scores of a lumbar spine, and we know that, DEXA often it can be inaccurate when looking at the lumbar spine in people that have spinal degeneration, scoliosis, kyphosis, fusions, instrumentation. How accurate and precise is REMS in people with spinal degeneration, scoliosis, kyphosis, verbal compressions, and can it be used for people who have had spinal fusions and or continue to have fusion instrumentation?
Absolutely. Because remember going back to the filtering, the sound wave that's going to come out of REMS with somebody who has spinal instrumentation, has metal in their back from surgery. That sound wave, that complex sound wave, the complex echo will contain the sound waves coming from metal. But remember, then REMS will filter it. And the AI is going to look for the sound wave that matches the profile of structural bone. Well, metal doesn't. It's going to get kicked out. Now, if there's not enough normal bone, if there's not enough structural bone to be assessed, the queue doesn't get filled, REMS will not give you a result. So there's a possibility, like if you have a kyphoplasty, if you have cement injected into your spine, and the majority of that bone, of that vertebral body now is cement, is now acrylic, is plastic cement, acrylic cement. Well, you can't do a REMS on that. I mean, REMS will not, you won't get a REMS on it. You can do a REMS, but you won't get a result because REMS is searching for that sound wave that matches the profile of structural bone. Well, bone cement is not structural bone. It's not going to go into the queue. So the queue doesn't get filled and that bone comes out gray. You don't get a result. But it doesn't get fooled by bone spurs like DXA does because bone spurs will block X-ray beams really well. Acrylic cement will block X-ray beams really well. Metal will block X-ray beams really well, so you'll get a fantastic DXA because DXA doesn't know what's blocking the X-ray beams. Whereas REMS is searching for that sound wave that matches the AI is searching for that sound wave that matches what it was programmed to look for. It has to match the database.
But you can get accurate information if someone has a spinal fusion and
Yes,
and the presence of hardware.
absolutely.
Okay.
And the worst, you might not get any result. You're not going to get a wrong result. So if you don't have enough bone, or if there's something that really has changed that signal, AI is looking for a particular signal. It doesn't find it. It's not going to give you anything. So you're either going to get an accurate result, as accurate as possible, or you'll get nothing.
Mhm. So, next question is, can REMS be used to track meaningful changes in bone density and bone quality over time?
That's a really good question. And I'm going to tell you, I can't answer it. I have an opinion on it, but I cannot give you a peer-reviewed um, answer from literature. I can give you anecdotal from my understanding of what it does, my understanding of statistics, and what I have seen in my practice. So I'm going to basically I'm going to answer the question, but it is my opinion. It's not something I can tell you. I can give you a reference for. So I think that that is limited because of statistics. So when the issue with REMS, and I want to be careful how I say this because it's not a REMS issue. I showed you the slides early on. I mean, particularly that slide where where they compared REMS to a CAT scan. I mean, this is the level of information coming out of REMS. It is fantastic. The problem is we don't have the technology, we don't have the knowledge how to use this information that's coming out the way it is. This is for the mathematicians who might be in the room. This is beautiful. This is a mathematical function that's giving you an assessment of your bone. It is pure. It's nature. The problem, again, we don't have the ability to yet use it in that form. So the best way to do it, what the Italians did was brilliant, is they built a computer model. They said, okay, since we cannot yet use this formula coming out of the bone as is, we're going to use a model where we compare you to healthy bone, to strong bone and weak bone. But those are going to be based on databases. And whenever you have a database, whenever you use a bell curve, because that's your statistical analysis, you're going to have some bias. You're going to introduce error. Because if you happen not to be the average in that curve, if you're off to the side, the statistics are not that strong as they should be. So what happens, and it's not just with REMS, what happens with DEXA and what happens with FRAX is that age is factored in as a risk factor for fracturing. And the assumption is made that as we get older, we're going to break. Our bones are going to become more frail as we get older. Now, there is some truth to that. However, I don't agree with what everyone's saying that you lose 1 to 2% of your bone every year. That might be the average person who doesn't take care of themselves. And I don't, again, this is being public and private. I will actually use some names of fast food restaurants, but probably most of the people who are listening to this webinar did not have dinner at a fast food restaurant tonight. But the majority of Americans do. And the database is built on the majority of the population and what it does, and the health of the general population, which is not healthy, especially as you get older. And as you get older, therefore, age is going to be a factor in making determinations. So So my experience with REMS, and but this is also true of Frax, and this is true of DXA, is that as you get older, the expectation is that you're going to get worse. So even if you stay the same, if in reality, if your body stays the same, just because you got a year older, what's going to be presented in your results is you're going to be worse because the statistics are going to push you up. Now, if you're staying the same, if you're taking good care of yourself, well, the change is going to only be statistical. Otherwise, there's no change. Now, if you actually are not taking care of yourself, or if something happens to you, a disease process where you start breaking bone down, well, the change will be substantial. It'll be statistics plus whatever is happening. So that's why these tests are still useful. I mean, what you're doing is if you have tests from year to year, you compare yourself, and if the progression of worsening is slow, well, then you know you're not changing. You're basically you're healthy. It's the statistics that are making you a little bit worse, but overall, what you're doing is working. Plus, you also haven't gotten sick. You don't have something that's destroying your bone. So that's the benefit of doing this. Even though what I'm kind of saying is that the results are tainted or biased as you get older. So again, not a simple answer. So I hope I answered the question, but it's not reliable. So what I go by is I look for small changes. I mean, I'm going to expect somebody's going to get worse. I haven't seen fragility score get better, but again, that has to do with the age bias that's incorporated in the statistics that's determining fracture risk. But now if the change is significant again, then that's indicating something happened.
Mhm. Okay, next question. Is REMS useful for monitoring response to osteoporosis medications or during medication holidays?
Okay. Oh boy. I hate meds. So let me just put that out there. I'm a traditionally trained doc. I'm not scared of Western medicine. I'm again a traditionally trained doc. I always looked at patients kind of, even as an orthopedic surgeon. So I was looking at somebody's ankle. Well, the ankle's attached to the rest of the body. You have to make sure the rest of the body will survive in the surgery if I'm going to try to fix an ankle. So I understood that. Now I might have done that myself. Being a carpenter, I had medical doctors that I trusted. But I was smart enough to understand I need somebody who's smarter than me to look at the person to make sure they're healthy. Because again, it's not just an ankle. There's a person attached to that ankle. So you gotta kind of think of it that way. Uh, it's the medications. Uh, I, so I was not anti-medicine because again, being trained as a typical doc, but again, having a bit of maybe understanding that you got to look at other things. The medicines always raised doubt in my mind at how they worked because you're disrupting the normal relationship between osteoclasts and osteoblasts. That's how the medicines work. And I do want to go into if we're gonna have some time at the end, we can talk about medicines a little bit. But you're disrupting that. So the uh, the bone you're making is not healthy. So having said that, we maybe put that to the side and we can talk about that otherwise. So, but the papers that have been published in Europe indicate that REMS can monitor changes within 6 months. So, and that has to do with the error rate of the physics of ultrasound versus the physics of X-ray. So there's a term called least significant change, the LSC, least significant change. That is the internal error rate of a densitometry measurement. So the LSC for DXA is up to 5%, which means you have to have greater than a 5% change from one study to the next in order for it to be considered valid. If you have a 4% change, that could just be the error of the machine. If you have a 6% change, then that's considered valid. And that's the reason why DEXAs are done every 2 years, because the way they look at it is, well, you have a better chance of losing more than 5% of your bone in 2 years versus 1 year. And that's the reason why DEXAs are 2 years, because of the LSC. The LSC, the least significant change for REMS, is 0.5% to 1.05%. So zero point 0.5 to 1.05%. DEXA is 5%. So that's the difference. So you can do REMS every 6 months and have a statistically valid determination of bone density if you're on a medicine. And there are studies, there are a number of studies that have come up in Europe with that. So the answer is yes. But I wanted to flavor that with the whole idea of why are we using these meds, and do you guys understand some of the issues with meds? And I want you to understand the physiology of those meds as far as um, should they be used. So again, maybe at the end we can go a little bit into that, or if there's more questions on that.
Okay. All right, next question. What strategies improve bone density versus bone quality, and how do they work together?
So again, who cares about bone density?
Mhm.
Paget's disease, bone um, I just keep on blanking the name. It's osteopetrosis. Osteopetrosis, Paget's disease is very dense bone. It's like chalk. It's fragile. It's brittle. So let's just get rid of density. That's really something that we shouldn't be measuring. That's not really what we should be talking about. So now quality. Again, quality of the bone is the structure. It's that slide that I had showed you with all those boxes. It's all these different things that are determining that are determining your structure. So the quality is the combination of these properties, and density's in that chart. It's just not they didn't put the box, but density's in here. So density is one of those properties, but it's one of many. So it's the combination of these properties and how they interact, which then determines your bone strength or your bone quality.
And
Now,
so,
so the question is, how do you maintain it? Was that the question?
what strategies improve density or quality, and how do they work together?
Okay, so we get rid of density, we talk quality.
Quality.
As you guys can see, I'm not a man of few words. I can answer that with one word: exercise. Drop the mic.
Okay, well, that feeds perfectly into the next question
Okay.
is high impact exercise necessary to build bone, or can strength training alone improve bone health?
Okay. There is a lot of discussion, and I am going to take a stance probably different than you guys are used to on this. So now, with T-scores, not only did I flip over the apple cart saying T-scores are useless, I'm kicking that apple cart off the cliff and it's floating out to the ocean. Forget about T-scores. They really are not reliable in determining if you're going to break. Strong bone doesn't break, weak bone breaks. You want to know your bone structure, you want to know your bone strength. Now, for exercise, I'm not going to tip the cart over, but I definitely want to rearrange the apples. So, the only thing that determines well, I want to phrase this. The major thing that the major factor that determines what your skeleton is the pull of the muscle on that bone. So, as we're all sitting here right now, and we're just sitting, we're not exercising, while our skeletons are assessing us because they have to. Our skeletons are constantly assessing us to see whether or not we need them. Now, that's not fair. I mean, we're not exercising, we're sitting. The skeleton doesn't care, it's judgmental. Because the skeleton is a very expensive piece of equipment. It costs a lot to have a skeleton. It's a lot of resources have to go into maintaining a skeleton, a lot of nutrition is needed. And the reason we're all here today is because our ancestors were very efficient. They survived famines, they survived wars, calamities, and that's why we're here. Not because they carried around too much bone, because they carried around the right amount of bone that allowed them to survive when food was not plentiful. So that goes into thinking physiologically how we build our skeleton. Now, the main the main force that the skeleton feels is the muscle. So the skeleton and muscle have a hand in glove relationship. You don't think about bone alone. You think about the bone muscle unit. If you have no muscle, you have no bone. And we know that from space travel, we know that from polio, we know that from spinal cord injuries. If the muscles are gone because the neck was broken and there's no nerve stimulation to muscles, so the muscles go away in somebody who had the misfortune of becoming paralyzed, the bone is very brittle. Now, you still have some bone. You don't turn into a jellyfish because there is some force applied to the bone through gravity. We all are living under 1 g of gravitational force, and our skeletons have adapted to that. Now, if we go to the moon, it's going to be 1/6. Our skeleton will change. If we go to Jupiter, it's 20,000 times or something, 12,000 times the gravity of Earth. Our skeletons would change. So our skeletons have a baseline based on the gravitational pull that we feel all of the time. That's about 20% of our skeleton. The other 80% comes from the muscle attached to it. And the bone does not care what you do to get the muscle. As an example, I use my arm bone, this bone right here, my humerus. The only thing it cares about is my biceps and my triceps. It doesn't care about anything else. It doesn't care how I got them. It just wants them to be strong. So I could do curls, I could do kettlebell, or I could hold my arm out to the side. Now, the difference is it might take me 5 minutes of doing bicep curls, and it might take me 20 minutes of holding my arm out like a yoga pose, but the strength is the same, and the bone will be the same. Now, the other difference is I won't hurt myself holding my arm out, but I could hurt myself doing biceps curls. So the form of exercise does not make a difference. I have yoga instructors who do no weights. These ladies are made of steel. They're as hard as a rock. And their REMS is fantastic. And they do no weights. So it's not weight bearing, it's not impact. It's it's resistance exercises that build muscle strength. And muscle strength is what the bones have mechanical receptors that are feeling the pull of the muscle. And again, as we're sitting here, those mechanical receptors are telling the bone whether it needs to stay or needs to go. And that's based on what we did this morning. That's what we did yesterday. Now, the other thing, kind of in that evolutionary idea about skeletons being expensive, muscles come and go very quickly because muscles save our backside. If we have to run away from a tiger or if we have to fight a war, the muscles will grow very quickly because that's going to save us. Well, when the muscles grow, they begin to pull on the bone. The bone feels that the bone grows. So the cart is the bone, the horse is the muscle. Without the horse, the cart goes nowhere. You attach a horse, the cart follows the horse, and it follows in both directions. So if your muscle grows, your bone will grow. If the muscle atrophies, the bone will atrophy. And that's how we survive because our bodies respond like that. The problem is in our generation in the 21st century, we live a lifestyle that promotes muscle loss. So that's why you have to actively work on keeping your body strong. But again, your bone doesn't care what you do. So there are three questions that I usually give patients as far as if they ask me, well, what's a good exercise? Again, as you see, a lot of times I don't give direct answers. I'll dance around it. So this is my dance. So if you ask me what's a good bone exercise, or is this a good bone exercise? I'll change the question and ask you, does that make your muscle stronger? If the answer is yes, it makes your bone stronger. Wolff's Law, 100%. So if your muscles get stronger, your bone gets stronger. The second question, is it safe to do? Now, that's an orthopedic question. So I kind of, in my example, I'm a 250 pound man. I fling around a 50-pound kettlebell. So for me, that's a good weight. 60 was too heavy, 40 was too light. Now, you ladies who might be 100, 110 pounds, would a 50-pound kettlebell make you stronger? Yes. Is it safe for you to do? No. You're going to tear your rotator cuff. You're going to pop a disc in your back. You're going to tear your hip labrum. You're going to hurt yourself. Now, 30-pound kettlebell, 20-pound kettlebell, yeah. But again, you have to choose what's appropriate for you. The first question also, let me pop a quiz on you guys and just maybe see if somebody wants to venture an answer or just maybe with a show of hands or something. Is who thinks swimming is a good bone exercise? I see just one hand. I don't see a whole lot of hands. I see a few hands. Well, ask the question, does swimming make you stronger? The answer is yes. Swimming is a fantastic exercise. Swimmers are extremely strong. Well, if your muscle's strong, your bone will be strong. Swimming is a fantastic bone exercise. Now, the next question is it safe? Well, if you don't know how to swim, no, it's not safe. You're going to drown. But yeah, so kidding aside, but that's how you, I think that's the best way. So if instead of me telling you what's a good exercise, I can basically say that's how you determine what's a good exercise for you. Will it make you stronger and is it safe for you to do? The third question adds to that. You don't have to answer yes to this, but is it fun? If it's fun for you, then you're going to do it. It's sustainable. And the whole idea of this is to do something that is sustainable, that will make you stronger, and is safe for you to do. That's, again, I think the way of paraphrasing the exercise question. I don't know if Susan, if you have anything to add to that. I mean, you obviously have a lot of experience with the exercise also.
What I generally tell people is exactly what you said, maybe a little bit more succinct.
Yeah.
Um,
Okay.
the bone follows the muscle. The stronger your muscles are, the stronger your bones are going to be. And I agree with you. Any exercise that builds muscle is going to build bone. And I believe you have to enjoy the exercise because if you don't enjoy the exercise, it will not be a sustainable
Mhm.
exercise program for you. So I think that's really important. And I mean, if you hate weightlifting but love swimming, what are you going to do as a weekly habit for your exercise program? Probably weightlifting, but not for very long because your pull is going to be towards enjoying swimming. So I agree with you.
Yeah. And it
Um,
can also be things like dancing. I mean, dancing is exercise. And but if you enjoy it, no, it's not. It's fun. You have a night out and you go dancing. Now, if you're exhausted at the end, that's fantastic. You had a great workout.
right.
Now, I want to put a caveat to that last question. So you don't always have to answer yes, because I don't think anyone likes squats. I don't think anyone likes planks. But you know what? You do your 10 minutes of torture. You hold your plank for 2 or 3 minutes if you're that good, and you hold your squat for 5 minutes. You know what? You're done. Then you go kayaking, or you go hiking, or you go dancing, or you go swimming. So you do your torture for 10 minutes, and then you have fun. So
Yeah.
now going back to impact. So as far as impact, the answer is no. Because your bone feels the impact while the impact is happening. As soon as you stop the impact, well, what's the bone feeling? No impact. So what's it responding to at that moment? No impact. Now, if you impact it constantly, that's different. If you're a kangaroo and you're bouncing, well, yeah, your bones will be different. But if you do heel drops once a day, no, it's not going. Your bone, that from an evolutionary standpoint, it doesn't make sense for the bone to grow from that because that is not something that is going to be necessary for you to survive. Now, if you're getting stronger by doing the heel drops, if you're building your butt muscles or your core muscles, then yeah, your bone will get stronger because the muscle got stronger. But in of itself, impact, no, it gets way too much press. It's not something you have to do. And again, it's really you focus on muscle. You focus on does this make my muscle stronger? And then that's true of vibration. That's true of everything. So does vibration build bone? I'm a skeptic. However, there is literature that supports that vibration actually builds muscle. Now, it doesn't do it very efficiently. I don't know if it's worth $5,000 for a plate for vibrating to build muscle. I think you're better off going swimming or going running or doing yoga or doing push-ups. But there is literature that's supporting when a muscle fibrils vibrates, it actually induces it to start building, to start hypertrophying, to start growing. But it's not significant amount. So again, I'm not somebody who promotes the vibration plates. I think they're good for proprioception. If you're standing on something vibrating and you don't fall down, well, you're working your balance. And also, obviously, if you're standing on something vibrating and you're not falling down, well, you are locking your muscles. I mean, you have to tense up muscles so not to fall. So there is some muscle building. So if you have one, use it. But if you don't have one, I'm not sure it's worth the investment.
Yeah. Okay. Next question. Once someone has had a REMS, how should they use this information, especially if their physician is unfamiliar with it or skeptical of the technology?
Okay. So for me, again, the most important part of the REMS is the second page, is the fragility score and where you're placed on that graph. Are you in the green? Are you in the yellow? Or are you in the red? Because that's your fracture risk. So if you're in the green zone, if your numbers are such where you end up in the zone where there is no one in that database who has fractured, who has the same numbers you have, then you have strong bones. And the other way of so your choice of activities is based on those three questions. Does it make your muscle stronger? Is it safe for you? Is it fun to do? So that's how I would use that report. And then year to year, you do comparisons. So one year you have a certain number, the next year you see what your number is the following year. And with the anticipation, it's going to get slightly worse because those are statistics. The statistics will push you up. And probably as you get older, and getting old sucks, it's not great. So there's going to be some breakdown in the body, but the same time, it's not the rates for this demographic. I'm thinking for the audience that we have today, your rate of fracture is not what's being quoted as far as the average rate, because you guys are taking care of yourself. You tend to be healthier, but obviously there's going to be some decrease, and then the statistics will. Well, that you look at DXA or any other test you're taking, it's going to probably make you worse year after year, but it should be only a small amount. So that's how you use it. You basically see where you are as far as your fracture risk, and then you see if you're getting year-to-year studies, what's happening in the course. How are you changing? Is it changing? Is it small or is it significant? If it's significant and something's going on, you need to be checked out, your doc, or you need to go to somebody who's going to make sure to see why is the change significant.
Mhm. And I think you pretty much cover this as well. How can REMS help guide decisions around medication, lifestyle changes, and ongoing monitoring?
Yeah, well, it's based on that. I mean, if you're in the green, whatever you're doing, it's working. You have low fracture risk.
Yeah. Okay.
Now, it doesn't mean you can't optimize. It doesn't mean there's things you can't add to keep yourself in the green longer or just to make yourself healthier. But overall, that's it. It's giving you I mean, basically, when you're in that green, what it means is the structure of your bone matches the structure of bone in people who have not fractured in your age group. So if you're in the green, there is nobody who shares your bone structure who has fractured. So that implies strong bone.
Mhm.
Again, low fracture risk.
Right. Okay, the next two questions are kind of in the same realm. Is REMS helpful for individuals with metabolic bone conditions such as hypophosphatasia, HPP? Um, so let's just start with that one.
Okay, so there's no literature yet that I'm familiar with that addresses that specifically. So I don't have a specific answer for that. Um, Overall, there is going to be a change in bone structure because phosphate is one of the components of the bone crystal, phosphorus or the phosphate. So based on my understanding of REMS and understanding of how REMS works, if you're having a change in bone structure because of a metabolic condition, then your fragility score will be will be worse. It'll indicate that the bone is weaker. So that's how I would read it. But again, I don't have literature to support that. I'm not familiar. I mean, they might have something. I haven't come across anything yet where that specific condition is discussed.
Okay. Is REMS appropriate for men with osteoporosis or secondary bone loss, including calcium wasting conditions?
It's sort of the same answer. I don't have literature to support that, but if the bone is breaking down, if any of these conditions are changing the structure of bone and weakening it, that's what the AI is looking for. It's looking for a change in the bone structure, regardless. At some point, again, with the slide I have that you guys are looking at right now, remember these are all the factors that determine your bone structure, and these conditions are affecting certain number of these boxes. So if these boxes are being affected, then the overall bone strength will be affected, and that's what REMS is measuring in its entirety right now. And I believe that in the future we'll be able to tell whether it's your collagen is a problem, is it the mineralization, your phosphate, your calcium, your magnesium, and that's a problem. Is it a porous bone or not porous bone? Are there microfractures? All those are boxes that belong in here or that are in here, and each box is producing its own sound wave. So at some point, I think there'll be answers to those questions, very specific answers to those questions. But right now, again, I'm not familiar with the literature, any literature that says that. And again, my understanding of REMS would be that if those conditions are weakening the structure, anything on this slide, the structure is changing. Therefore, the fragility score would be different, would be affected by that. So I think it will, but again, I don't know. I don't know. I don't have a definitive answer for that.
Okay. Is REM still beneficial for individuals who have previously taken osteoporosis medications?
Yes, and so majority of the osteoporosis medications are altering the bone structure, which is a problem, which is not good. It's made to sound like it's good because in many ways of how it's done, it increases density, so it makes your DXA T score better, but it doesn't change the structure of your bone. or if it affects the structure of your bone. And remember, REMS, when it's filtering, it's looking for a certain pattern of structure. If that structure has been modified by medications, it may not be examined by REMS. REMS might exclude it. Or it's going to indicate the structure is not normal structure and it'll be read as weaker bone. And again, I don't have literature to support what I just said, but that's based on my understanding of the physics of how REMS works. But that also goes into my point of why I don't think the medicines do what they claim to do. I'm very skeptical. And again, if we have some time at the end, I think maybe that would be something to go into a little bit too.
Mhm. Yep. I'm almost through all the questions I got previously.
Oh,
Um, who is the ideal candidate for REMS, and are there individuals for whom the scan may not be appropriate or useful?
everybody. And the younger you are, you should get a scan when you're young, but not every year. I mean, if you get it when you're 30 and you're premenopausal, you wait 10 more years, or you wait 5 years, and you get another one at 35 or maybe 40. So there's no protocol set up yet. But obviously, it's not a bad idea to get a baseline when you're younger. Then otherwise it's fine for everyone. Now there are limitations, and in what the manufacturer says, and also my own experience, somebody who's very little or very large is very hard to get a REMS on because of the limitations of the actual machine. So I've had ladies who are so little, so thin that when I'm looking at their L3 vertebral body, I'm not touching their skin. I am actually pulling the probe off of their body, and what's connecting me to them is the gel. Because they're so thin, if I put the probe on their abdomen, the sound wave, the focus is actually below their bone. I can't bring the focus up because they just don't have they're so little. They're BMI of 15 or 16. They're tiny. So that's where the limitations are with REMS. It's somebody very small or somebody who's really big. If someone has a really big belly, it's just then the sound wave again. There's physical limitations to the equipment, to the machine.
Mhm.
Other than that, no.
How about people with hip replacements or other joint replacements?
So you can't do it on again if you have a hip replacement, you don't have a femoral neck. So again, there's nothing to measure. Now, if
Mhm.
you have a hip resurfacing, so where you just put a cap on the hip and the neck is still bone. I've done REMS on those. You can't do DXA on those because DXA will overread the hip, overread the metal. You can do REMS because REMS is searching for the structural bone, and there still is structural bone in somebody who has had a hip resurfacing, but not a hip replacement. Somebody has fusion, has spinal hardware in. Again, REMS is looking for structural bone. The metal coming out, the reflection of the sound coming off the metal, it's not structural bone. It gets kicked out. REMS ignores it. So again, if it has enough structural bone, you'll get a read, even though you might have metal in your back. Again, but for a hip replacement, the femoral neck is resected. We cut that off when we do a hip replacement. So there is nothing to examine. And I know that because I have done REMS on people with total hips, and you don't get a result.
Mhm. Okay.
Yeah. I sometimes do that still. If somebody tells me they have a hip replacement, I forget. I start examining their hip, and I'm like, why can't I get this? And they say, well, doc, I told you I got a hip replacement. Oh, so I've proven it a lot. Yeah.
Um, does Medicare or other insurances currently cover REMS scanning?
It does not. There's something called a T code. So there's some confusion. People say, well, there's a T code. That's a temporary code. For a doc, that's a danger zone because that means that they can pay whatever they want to pay for a REMS. They can pay 25 cents, and then you have to take it as a doc. So the machine is, you know, it's an expensive machine, but the reimbursement it could be $6. And I'm not joking about that. I mean, it's 25 cents. I was joking. $6. I'm not. That's the reimbursement for an otherwise unspecified ultrasound is $6. Just it's nuts. Our system is crazy. So
Yeah.
no, there's no code yet. There's no CPT code.
Okay. Um, what should someone wear to a REMS scan, and how should they prepare?
So the preparation is we in general everyone who's doing a REMS will request the person to not eat before the test. Now it's not a strict NPO. It's not like when you get a lab and if you eat something before the lab, you can actually screw the lab result up. With REMS, we ask you not to eat because we want to decrease the amount of gas you have. Because if you eat, you're going to make gas. If you make gas, that can get in the way. Now, I had a lady who had a smoothie right before she had her REMS done today. I struggled a little bit. She had a little bit of gas. I still got her REMS, no problem. So I don't cancel people if they've eaten, but I will ask them not to because it does make it a little easier. The other thing is you want loose clothing because for REMS you want to access the abdomen. It's very much like an OB ultrasound. So we're actually have the probe over your belly. So I need to see your abdomen from your rib cage down to your belt line. And then for the hips, I don't have my patients or my clients disrobe. However, I mean I obviously keep them covered, but I do ask them to leave their underwear on, but to bring their pants down to about mid thigh, and that gives me a good target for the hip. So it's loose clothing so that you can basically access the abdomen and access the hips. And those are the only two preparations.
Mhm.
I know for DXA you shouldn't take calcium. It makes no difference with REMS because again, remember REMS is looking for structural bone. Calcium pills, that sound wave is REMS will ignore it. So there's really no other restriction for REMS. And the food really is only so that it's a little easier to do the scan. So it's not a strict NPO. You can drink water, you can have coffee, you can have tea, but just something like a meal. Try to keep it a few hours, like like 3 or 4 hours away from a REMS. It'll just it'll make it easier for the examiner to examine you.
And I know when you do your scheduling for REMS and when I schedule the REMS, we also send out an email a few days ahead of time with all of the preparation
Yeah.
um, literature.
Yeah.
Um, is REMS intended to replace DEXA or does it serve as a complementary tool?
So DXA just measures density, and the reason why. So again, there's a little bit of history. So um, density is one property of bone. Again, in this slide, I lift up this slide specifically because this is really what bone is made out of. These boxes are all what bone's made of. And density, they don't have density as one of the boxes, but it should be. So density is one property of bone, one physical property. Whether you break, that's not a physical property. That's a behavior that's based on your physical properties. So whether a bone breaks or not, the bone strength, it's all based on all of these factors, all these properties. So 30 years ago, the only way you could even kind of come close to guesstimating whether a bone was going to break is by measuring density. The better property to measure is called elasticity. A bone's elasticity, it's its ability to accept the force and not break yet. And when you pass the point of elasticity, then you break. So if you could measure elasticity, that's a much better way of determining whether you're going to break. The only problem is the way you have to measure elasticity is you take a piece of bone out of the body, you take it to the laboratory, and you stress it. Well, nobody wants their bone taken out of their body. I mean, that's defeating the purpose. So they used density as the next best thing because obviously you could do it with an X-ray, but it's not accurate, it's not reliable, and it was cutting edge 30 years ago. 30 years later, we know that density is not a reliable way of determining whether you're going to break. It's bone structure. So DEXA should go into the journals of history. It was a stepping stone that gave us a better understanding of bone at the time. Now we're moving to a better technology, which is actually giving us structure. So the DEXA people may want to say, well, yeah, DEXA and REMS should be used together. No, there's no reason for it. DEXA is giving you density. Density is not a property that is not a way of determining reliably determining whether you're going to break or not. You want to measure structure. So in my opinion, REMS is replacing DEXA. It's a matter of time, 5 years, 10 years, maybe on the long end. But ultrasound in general is the future for medicine.
Mhm. Okay, so we're going to move on to some of the questions that people have put into the chat tonight. But before I do that, I just wanted to let everybody know that we do have two REMS events coming up in Virginia. One is in Northern Virginia in Fairfax, Virginia, at the end of this month, January 30, 31st. And then we have scheduled another event in Richmond, Virginia, which will be March 27th and March 28th. And I put the links in the chat to both of these. Also, Dr. Bush frequents Northern California, where he has an office and he does REMS in Northern California as well. And Dr. Bush, where else are you scheduled in the near future? Obviously, your
So
office.
Yeah, so I'm in North Carolina. I have a bricks and mortar here in North Carolina. So if I'm not traveling, I'll be down in a little town called Pittsburgh, North Carolina. It's just south of Chapel Hill, a little bit south and west of Raleigh. And I have ladies who fly into RDU Airport, Raleigh-Durham Airport, and then it's a quick drive down to Pittsburgh. So in California, I go out once a month. I work with Marsha Samuels, and we have our practice out there is called OsteoScan, and we work out of a dentist's office, out of a holistic dentist's office in Marin County, Marin Dental, uh, Marin Dental, just forgot not lifestyle. It's Marin Dental, and it's something else. So it's a holistic dentist office. And again, dentists are big proponents of REMS. Dentists hate the meds. They think REMS is fantastic, and what we're doing. So we're working at a dentist's office. I'm going to be in California from the 23rd through the 27th of this month. In February, I'm going to be going out in California from the 13th to the 16th. If you look in up OsteoScan USA, that'll have our schedule for California. So if any of you ladies are out in the San Francisco area, Marin County, actually Mill Valley, that's where the dentist's office is. I also go to South. I'm beginning to go to South Carolina more routinely in Charleston with Miss Jenna Davis. She's very much like Susan is, the same background. She has more of a nutrition background, but she does some stress management, some physical therapy. So she's developing a program down in Charleston, South Carolina. I don't have any dates set up for that. And in North Carolina, I work a lot with the osteostrongs. So Hickory, Wilmington, Mooresville now, they all have events or clinics that they schedule 2 or 3 times a year, and I'll go out and I'll do a REMS at the clinics. I don't have anything posted on my website yet. I'm working on my website, so probably in a month or two, I'll have postings as far as if you guys are anywhere close to. So, if North Carolina's a little too far, but I'm going to be close to you, that should be posted. I mean, Susan will have it posted, and in California, Marsha also does the postings. And I think once South Carolina gets up and running, Jana will have that posted on her website. But I will also, I'll get into the 21st century, and I'll have a website that's up to date. Um,
All
month or
right.
two, hopefully. All right.
So to move on to the questions from tonight, the first one is the hip, the only area scanned by the REMS. We talked about how it's scanned by you scan the spine as well, but later in the questions they asked about scanning the wrist with REMS.
The answer is no. There's no protocol for that, but you don't have to because what you're doing with REMS is you're looking at bone structure in the hips and spine, and the structure of the bone is should be the same no matter where you're looking in the body. Now, the wrist is kind of traditionally used if you're suspicious of hyperparathyroidism. Hyperparathyroidism will cause breakdown of the cortical bone more than the trabecular bone, and the wrist has more cortical bone than the hip or the spine. So the traditional use of the distal one-third of the non-dominant forearm or the wrist was for suspicion or for folks who had diagnosis of hyperparathyroidism. But REMS, you don't have to do it because it's looking at bone structure in general, just in general. So density is not what we're really looking for with REMS. We're looking at bone structure.
How often should a REMS be done?
Good question. So I, for most of the ladies who come through my office, I give them kind of a double answer. And first, I'm very blunt. I said, if I think you need to have a REMS next year, I will tell you that. I will come out and say, come back in 6 months or come back in a year. I don't hedge anything. Otherwise, I'll hedge it a little bit and say, I recommend a year because REMS is a screening test. Now, we use it to see whether what we're doing is working or not. We like the questions you ask, how much are you changing? And you're getting that information. But REMS is a screening test looking for catastrophic bone loss. So it's very similar to a mammogram. You get a mammography not to see the health of your breast, but to see whether or not you have a density there that you didn't have last year. So REMS is the same thing. You're looking for this significant or catastrophic bone loss. So that's the purpose of doing it every year, is the sooner you catch that, the more likely you are to be able to treat it in a timely manner. Now, to all honesty, I've been doing this 5 years. I've done about 3,000 scans. I have never seen catastrophic bone loss, and I probably never will. So as a doc, I have to advise a yearly exam. However, I have ladies who come to me every 18 months, or they skip a year, they come back 2 years, and I always kind of kid around and I promise them, I say, I'm not going to yell at you. If you decide you want to skip a year, you come back, we do your REMS, and we'll talk. So if you're better, if you feel better about doing it yearly, then by all means, I think that's the appropriate way to do it. But if you happen to skip a 6 months or you skip a year, if you're okay, if you're healthy, and overall the health hasn't changed, you're probably going to be okay. So again, I'm kind of dancing around that answer. Right.
Is REMS used in Italy instead of a DEXA scan?
My impression is yes. It has become the official method of performing bone assessment. And Italy has a nationalized healthcare system. So I think in 2021, they made REMS the official method of bone assessment. So it's not they don't have DXA machines, but I think they're and again, it's an Italian company, so obviously I think they're proud of it. So that's, they're using it.
Somebody asks, how come this is the first time I've ever heard of REMS?
Join the club. Let me tell you a little story, and maybe this answer the question. I'm a member of the International Society of Clinical Densitometry. It's the society that does the standardization of DEXA examinations. It has testing. It has courses. So I went through the ISCD course, and I feel I can interpret DEXAs because of that reason. It's a really good course. It's a really good organization. Every year they have, every 5 years, the docs who are in the leadership of that organization will ask the membership for ideas to do position papers. And they'll choose 5 or 6 topics and they'll write papers on it. And those are the papers that the docs in the trenches read, that we read. Because obviously, if I'm taking care of all these things, I don't want to, we have to read 100 papers. I want to read one paper that tells me, okay, this is a summary of all the papers that are out there. So about 4 years ago, that when I joined ISCD, the year that they were coming out to review ideas for papers, I submitted REMS as an idea, and I actually submitted as a 13-page paper with 56 references. I mean, what I wrote could be published. I worked with Echolight. I got all the information about REMS, what it is, what was collected up to that point in time, and I submitted it. They came back to me. They didn't think REMS was important. So they said maybe 5 years from now. So if you notice, there's nothing bad about REMS in the literature. If you Google, and that's what I recommend people do. If you're thinking about something medically, Google problems with whatever you're looking for, because you'll get a lot of good stuff, but you want to know what the problems are. So Google problems with radio frequency echographic multispectrometry. If you use REMS, REMS stands for a lot of things. So you got to do radio frequency echographic multispectrometry. There's not a whole lot out there. I don't think there's anything out there that's valid, because the problem with REMS, it's being ghosted. There's not a problem with it. It's just no one's talking about it. And my opinion of that is because they know that the time for DEXA is limited. And all these folks who are the leadership in these organizations and the policymakers, they're all invested in DEXA. They all have DEXA machines. Those are really expensive machines. The reimbursement is horrible. Reimbursement for a DEXA scan is $39. The machine is over $100,000. So in the infinite wisdom of our policymakers, they think $39 is a good reimbursement for a test on a $100,000 machine. I mean, that, as a doc, I mean, I was going to get a DEXA machine. When I saw that, I mean, I didn't put my money down because my grandkids would be paying that machine off. So these folks are invested in the machines. They're getting money from the manufacturers for data collection. So they're living off of grants because the insurance companies don't pay anything. And therefore, my opinion is they're not going to bring in another technology that can disrupt their ability to provide care, because obviously insurances don't pay enough. Again, I personally went out of business from my medical side because in reimbursement from insurance, I couldn't pay my employees. So the problem really is our healthcare system. The folks who make the decisions, they're invested in something because you have to be. You need a technology you based on. They based it on DEXA. They're seeing the changes happening, and I think they want to do it in a way that they can get out of their burdens that they have with this technology that's dated. So that's my opinion what's going on. Now, I submitted another proposal to the ISCD. The 5 year cycle is coming around, so I just submitted another proposal, I rewrote that paper. So I'm waiting to hear from back from them whether or not they're going to look at it. But the answer 5 years ago, we didn't think it was important. So again, that's a long-winded answer, but that's probably why you haven't heard of it.
Okay, next question. Regarding nutrition, is it possible that calcium isn't getting to the bones and results in bone loss? It and results in loss of bone strength.
You want to venture? I mean, we can work on that one together. Do you have an opinion, Susan?
I do think that there's the possibility. I mean, calcium is the foundation for the bone structure, or one of the foundations for the bone structure. So I do think it's important. I don't think it's the be all and end all to bone strength by any means. I think it's been way overblown in our medical society. But I do think that there are potential issues with absorption. And as you know, Dr. Bush, I'm very adamant and intrigued by the gut bone connection and absorption, not only for the bones, but for our health in general. So I do believe that there can be issues with calcium absorption in the digestive tract, and therefore, if you can't absorb calcium, it is not getting to the bones. So I think that there's a potential that yes, if you cannot absorb calcium, it can't get to the bones, it would result in bone loss and decrease in bone quality.
And I agree with Susan. I punted to you because you have the expertise to that, and I agree 100%. It's gut health. You have to know your gut health because if you're
Mhm.
not absorbing calcium, now calcium does not build bone. I'm just want to spread off that exercise builds bone. What calcium does is after you exercise, your muscle and your bone are looking for the nutrients so they can build. That's where you need the calcium. So the calcium alone does not build bone. Nothing builds bone except for muscle pull, except for exercise, strengthening muscles. But again, if you have a problem with absorption, if your gut's not healthy, you may not be absorbing the calcium, and then when your muscle and your bone are looking for the calcium, it's not there. The structure is going to be compromised. So.
Can someone with good, strong bones fracture because of the angle or the intensity of a fall, or are all fractures the result of poor bone?
No, I mean that's why have a job as an orthopedic surgeon. Bone is a structural material. You overload it, it can break. So you fall off a bicycle and you break. That's not a fragility fracture. That's a broken bone. Now, if you're frail, yeah, you can still break. But you have kids who are breaking all the time. You have people who ice skate, people who have again, as a trauma surgeon, I see it. That's what I was doing. I was putting people back together who either had the misfortune of having an accident or who did something dumb and broke their bones. So no, it not fractures are actually you try to delineate them into high energy, low energy. So a motor vehicle accident, an accident on a bicycle, an accident on a skateboard, on skis, those are high energy injuries. If you trip over your kitty cat in your living room and land on the rug and break your hip, that's low energy. That would more likely than not be a fragility fracture. Whereas if you fall off your bicycle and you break your hip, probably not a fragility fracture. It's more likely than not a high energy fracture, and anybody would have broken. Again, you just happen to hit the ground, the right angle, the wrong angle, whatever you want to call it. But it was enough force that overloaded the bone and broke. Again, you see bridges fall down, you see buildings fall down. Well, the building itself overloaded the steel beams that was holding it up. The steel beams failed and the building fell down. So yeah, you can overload a structure that might be fine.
Okay. Question is, how hard is it to find a provider that can do a REMS test instead of a DXA? And that's pretty tough.
There's not too many around, and one of the problems with happening with REMS is it's kind of the Wild West. So a lot of facilities that are not necessarily medical are getting REMS machines. Now, not to say that the owners of these facilities aren't competent people and aren't, and a lot of them are focused on building muscle, building strength. So for them, REMS makes sense. But there are more places, so it's not that hard to get one. It's going to get harder. It's harder though to find someone who can explain it to you. And again, the thing is, people can say, "Oh, your T score in REMS is this. It's fine." Well, why bother getting your REMS if you're getting a T score? I mean, T score doesn't predict fracture. You want somebody who can explain the fragility score to you, or explain you, educate you what that is, and kind of that's what we've done. I mean, that's what Susan and I have set up tonight, is to kind of give you guys the understanding that hey, it's the fragility score, it's the structure of your bone that's going to determine whether you break or not. If you have strong bone, you're not going to break. If you have weak bone, you're going to break. It's not density. It's the strength. So that's where the problem is. So there's not very many docs. Dr. Zambito, myself, Dr. Vaught up in Chicago, a few other docs, Dr. Kushtieva down in Florida. A few docs have it, but other facilities, a lot of osteostrong facilities now have them, and then I think some chiropractors have them, and some other ancillary medical folks have them. But the issue will come down to are these people, do the folks who have it, or do they understand really what they have? Do they understand? Can they educate you as to what the reports mean? I mean, they can interpret it for you. A doctor has to interpret it. But again, even now, I'm not interpreting anything for you. I'm educating you. So will they be able to give you that level of education so that you have an understanding of what you just got? And that's where the problem comes in. It's more than finding one. It's more than finding somebody who can explain it to you.
Mm-hmm. And I think this question goes hand in hand what you're saying, explaining it rather than just telling you what your scores are. If a person's fragility scores are in or near the red on page 2, what is important for them to do?
So it's for me that sends up a red flag. Obviously, that indicates that fracture risk is elevated based on bone structure. Now, you don't base something on one number. Again, you don't base something on one T score, which is kind of very common. But you also don't base it on a single fragility score. So when I see a fragility score that is high, and I want to see that person who generated that score because there are a whole lot of things to consider. And this could be another lecture where you start talking about statistics. And is that elevated number due to the person having weak bone, or is it due to a statistical bias that's being introduced because of age? So you have to assess that. And then obviously, again, you go back to the person. Is the person who's sitting in front of you a frail person? Sometimes you can see it, sometimes you can't, but a lot of times you can see. And I have ladies who come into me having their doctors telling them that they're going to break if they sneeze or something. And I look at this person and there's no way that she's frail. And no, I mean, and her point is like I exercise every day. I lift weights. I do this. I do, and my doctor's telling me I'm frail. And I look and I say, no, you're not frail. You're not a frail little lady. So again, I'm kind of dancing around an answer with this. It does send up a red flag, but I'm not going to use one number itself to say, well, yes, it's you have to absolutely have medication. Consider medications. Again, I'd like to go into that topic, but other treatment, or we have to work you up. Why are you up there? And it doesn't make sense for you, and it looks like everything is done correctly. Why are you there? Now, if someone comes in with, who's sickly, who has kidney disease, maybe significant chemotherapy use from cancer, otherwise very, very malnourished. Well, that's going to explain an elevated fragility score, yes, because they are frail. And then you come into, okay, how do you decrease your fracture risk? What do we do to try to decrease the chance of you breaking? Because REMS is saying you have high fracture risk. So I don't know if that answered the question. Again, it's not a simple answer. It's multifactorial. You got to look at the person who's in front of you, and that goes into the assessment. But REMS gives you a signal. Hey, this person might have something going on.
But I think also what you and I, or what you have found and have pointed out to me, is again that age bias.
Yeah.
And so, because, and correct me if I'm wrong, the REMS technology uses age to determine the fragility score. It just automatically assumes that if you're older, your bones are going to be weaker.
That's built into the database, and that's
Hmm.
the problem. So REMS does overpredict fracture risk when you're older. I have seen it 100%. I have ladies who fall off of horses. They're 70 something. They're riding horses still. I mean, they're not frail. They fall off the horse, they don't break. Yet REMS has them at a high fracture risk because they're 75 or 76 years old. but they just fell off a horse and they didn't break anything.
Mhm.
So that is now REMS does not underpredict fracture risk. If it underpredicted, it would be as useless as T-scores. But it doesn't underpredict. But I have seen that, and that is a bias, and that is actually not a REMS problem. It's not specifically a REMS problem. Frax has the same problem, and DXA has the same problem. And what I do is when folks come to the office, if we have time, I take them through something called Frax, and Frax is a way of determining fracture risk without doing REMS or DXA. It's a questionnaire. So if you guys want to do that for yourselves, just go to Frax, Frax, go to Frax Calculator, Frax Calculator. It'll usually take you to the University of Sheffield in England where they developed it. But you'll get a questionnaire with 11 questions. The first 10 questions are going to be your age, your weight, your gender, whether you smoke, whether you drink, uh, does mom or dad break a hip? Did you have a fragility fracture? Do you have any reasons to have secondary osteoporosis? That's the only time they will even use the word. The last question is your BMD value, and I never enter that. You cannot use REMS, and I don't trust DXA. So I just leave that blank because that's a new add-on question. The original fracs never had BMD values. Then you get a number. You'll get a risk for your spine. You'll get a risk for your hip. To see what I'm talking about right now, if you get those numbers, make yourselves 10 years older. Just go back and change your birthday or change your age from 65 to 75. Don't change any other question and then see what your risk factor is again. And I can tell you your risk will double, your hip risk will triple by just changing your age, not changing anything else. So you can see how age is incorporated into the algorithm that predicts fracture risk. Because in our society, age is the most important determinant of fracture risk because we are not healthy. It's assumed as you get older, because of our lifestyles, we are getting sicker as we're getting older. So our fracture risk is increasing, and age is driving that. So that's again, it's not just a REMS problem. DEXA does the same thing, and Frax. I mean, you can do Frax, and you can see for yourselves, it does the same thing.
Um, so I want to ask one more question because I think this is a really, really pertinent question these days. And then if you would like to go into medications, it's about 20 of 9. We could spend 15 minutes on
Okay,
medications if you'd
sure.
like. Okay. Um, are you concerned about the muscle wasting side effects of GLP-1 agonist? Oh, wait a minute, something just changed here. Medications and the effect on bone integrity?
Absolutely.
Me
Um,
too.
there's some papers come out in the orthopedic literature about that, about muscle loss. Now, I'm not well read on that. So I really, it's when the reason I jumped at that answer and said yes immediately is because muscle is key to survival. Right now, the field of longevity medicine, that's kind of a new field coming out, and the ideas of longevity medicine are not to make you live longer. Their design is for you to live healthier longer, to live a healthy, independent life for the period that you're going to live. And the basis of it, if you look at the basis, it has to do with muscle. Everybody talks about maintaining strong muscle because the thought process now is we don't lose muscle because we're dying. We die because we lose muscle. Sarcopenia is believed to be the cause of death. So you waste away, your muscle wastes away. Muscle's an endocrine organ. It balances hormones. It's insulin it metabolizes insulin. It produces energy, ATP, and it maintains your bone. You lose muscle, you die. So that for me, when I hear that any medicine that'll waste muscle, and it's statins, it's the GLPs, it's all of these, it concerns me. But again, this is Dr. Andy Bush opinion. I have to be careful. I can't say that I have literature to back what I'm saying. But the literature does back the muscle. The fact that muscle is an endocrine organ that's as important as any other organ in the body. And muscle loss leads to a loss of health. So
Absolutely.
yeah,
And it's interesting because I think there was even a 60 Minutes show um, in the fall about the importance of maintaining muscle mass as we age. And the
yeah.
number one thing that predicts healthy aging is your muscle mass.
Yes.
So it goes hand
Yeah.
in hand with the bones.
I thought this was weird, but at one point I had the grip strength determines mortality. And I said, how can that be? Well, it makes a lot
Yeah.
of sense. Yeah.
Yes. Yeah. Okay. So we're going to venture into medications, and we're just going to start with this one question. Are there any situations in which you would recommend medications?
Yes. High fracture risk determined by REMS and then substantiated by the examination on the patient. Or high fracture risk determined by REMS and then a patient being more comfortable taking a medicine. So, and the only medicine I use is Avista. It's raloxifene. It's a SERM, a selective estrogen receptor modulator. So, Avista is the common name, raloxifene is the generic name, and it's a selective estrogen receptor modulator. And the reason I believe in it is because I believe in hormones. And I come from a very, now again, I'm a carpenter. I'm an orthopedic surgeon 30 years. What the heck do I know about hormones? I mean, again, I've learned some recently the past 2 or 3 years, but again, now even as a guy, what the heck do I know about estrogen? So I'm lucky here in North Carolina. I have docs who are in Raleigh, who are in Durham, Chapel Hill, who are brilliant. These ladies are brilliant. They're ladies. They understand estrogen. So I'm fortunate where I can just get my clients or my patients up to these doctors, and they'll take care of the hormones. But what I do is I'll twist my patient's arm into talking to one of the docs, Dr. McGregor or Dr. Denny or Dr. Meredith. But I will never twist their arm into taking the hormone because it's a decision you guys have to make for yourselves. You have to be comfortable with the information you get to put that in your body. It's one thing for some guy to tell you to take it. It's another thing for you to actually put that in your body. So you have to be really comfortable with it. But again, I'm lucky here where I have docs here in this area that I can refer to. So again, they're smarter than I am. They know what they're doing. And again, they're ladies. You probably want to talk, not that a guy can't answer your questions, but again, what do I know about estrogen? I mean, I know a little bit about testosterone, but so for hormones, I believe in them. You guys are ladies. Ladies need estrogen. You were ladies 20 years ago. You're going to be ladies 20 years from now. You needed estrogen 20 years ago. You need estrogen 20 years from now. You're a woman. Your body needs estrogen. I'm a guy. I need testosterone. My body needs testosterone. So just from that concept, I'm a big proponent. Now, I don't do it for bone health. I do it for the fact that you're a woman and you need estrogen, or I'm a guy, I need testosterone. But then your skeleton, your brain, your heart, thank you for taking the hormone because your body needs it. You have estrogen receptors. Now, the SERM, it's not estrogen, but your body thinks it is. So when you take Avista, it'll bind to the estrogen receptors in your body. And it'll make your body think instead of acting like a 65-year-old body, it acts like a 45-year-old body. So that's how it affects bone. It doesn't build bone. Estrogen does not build bone. Raloxifene or Avista doesn't build bone. But what it does is when you apply a force to your bone, when your muscle pulls, then your bone responds like a 45-year-old woman, not a 65-year-old woman. So that's how I approach hormones. That's why I believe hormones are important. The bioidenticals the black box warning was just recently taken away from them. And then if a patient doesn't feel comfortable with hormones or there's a contraindication to it and they want to be in a medicine, the only one I prescribe is Avista. I do not use anything else, or I would not give anything else. Now,
Is it,
that's a pretty recent thing in my how I made recommendations because I used to recommend some other meds. But as I learned, I had a gut feeling about the meds, as I learned more about it, and then what really pushed me over the edge was the fact of how the pharmaceutical industry is presenting the statistics. They are presenting them in a misleading way. So first, let me just go a little bit about what the meds do or what they don't do. So the medications do not build physiologic bone. They're building unhealthy bone. Because what the medications do is they disrupt the normal relationship between the osteoclasts and the osteoblasts. You have a relationship between the two. The osteoclasts go in and they start breaking down bone. And the osteoclasts, the cells that break down bone, they get a message from the osteocytes, which are the cells that live inside the bone. And the osteocytes perceive the change of pressure, the fact that the bone is being pulled on. They feel the force. And they send a message to the osteoclasts, which then go to the area where this force is being applied, and they start breaking bone down. They then signal the osteoblasts to come behind them and to put bone down. So all of this is working together. They're all friends. Well, what do the medications do? They disrupt that. Some of the medications knock off the osteoclasts, the anti-resorptives. They either suppress the osteoclasts or they actually push them off the bone so they die. And then the osteoblasts just come and they start putting bone down randomly. Well, what could possibly go wrong with that? I mean, osteonecrosis of the jaw, atypical femur fractures. Because you're not responding to muscle pull, you're randomly putting bone down. The anabolics do the same thing basically. They suppress the osteoclast a little bit, but they goose up your osteoblasts that just start putting bone down. Again, they're not responding to muscle pull. You put on 3 pounds of muscle, you're going to put bone on. Maybe not 3 pounds, but you put an equivalent of bone on. And as long as you have those 3 pounds of muscle, the bone's not going anywhere. You lose that muscle, you lose the bone. That's how you build bone, is only through muscle pull. These medicines, they put down bone non-physiologic. So that's why when you stop the medications, you lose the bone because there's nothing to maintain it. You don't have the muscle to maintain it because you didn't build muscle. You just slap some bone down, which is not physiologic, which is not healthy. Now, how does the pharmaceutical industry present this? Well, there's two ways of determining whether you should be using a medicine. And the first way is called absolute risk reduction. And that's what you as a patient want to know before you take a bone medicine, before you take an antihypertensive, before you take a statin, is how much does this medicine decrease your chance of breaking, your chance of heart attack, your chance of stroke? And the way it's done is you have a room of 100 people. If the risk of breaking a bone is 4 out of those 100, you take the medicine, the risk goes down to two out of 100. So it's a risk reduction of 2%. It's an absolute risk reduction of 2%. And that's how it should be presented. Now, if you're deciding whether you should take a vaccine, well, you don't have the disease. You don't know if you're going to get it. And what determines that? Well, it's your health, the health of the people who are around you, your exposure. It's all these factors that are unknown. So you're not going to use absolute risk. You're going to use relative risk. And relative risk is looking at absolute risks. So if you have 100 people in the room, four of those 100 will get measles if they don't have vaccine. If you give a vaccine, only 2 people get measles. Well, that's a risk reduction from 4% to 2%. That's a 50% risk reduction. But that's for vaccines. The pharmaceutical industry uses that for bone meds. So if you hear that Fosamax decreases is fracture risk reduction between 30 and 60%. That's relative risk reduction. The absolute risk reduction of Fosamax is zero point 0.6 to 1.8%. It's less than 2%. So the number you should be using to determine whether you should be on Fosamax is less than 2%, is 1.8%, not 60. When I hear that, it really pisses me off. Because if a company is making a product that is really good, they don't have to do that. They present it the way it's done because it's going to sell itself. If you're selling a product that has, then you're going to do what you have to do so people take your product. So it's again that bothers me. So from my opinion, I don't recommend the use of any medicine other than Evista. Again, Evista doesn't build bone, but it helps you physiologically build bone. And Susan, I don't know if you have a point.
Somebody just asked, what is the absolute risk reduction of Evista?
I don't know. I don't know that offhand.
Okay.
Yeah. I can tell you
Um,
Avinity is less than 3%.
okay.
So I don't know for Avista. I look at Avista though as the fact that it's physiologic. It doesn't build bone. Again, it doesn't stimulate one thing or the other. It's when you exercise, you're going to build bone and you're going to build it in a physiologic way because you're going to build it as a 45-year-old woman, not a 65-year-old woman. So it's like hormones. Avista is a surrogate is an analog for hormones. And again, obviously you can see I'm a proponent of hormones.
Okay. What about Forteo, which stimulates parathyroid work?
Well, so Forteo is a parathyroid analog. So Forteo and Tymlos, one of them is an analog, one of them is a metabolite. And again, when you have scientists who do what scientists do, they do crazy things. And somebody was smart enough or crazy enough to figure out that even though parathyroid hormone tends to stimulate osteoclast function, which is bone breakdown, because that's what parathyroid hormone does, is it's released when your calcium levels in your blood drop. Well, someone figured out if you give a small dose every day, it has a reverse effect. It actually suppresses osteoclasts and stimulates osteoblasts. But it's still not physiologic bone building. What you're doing is you're goosing up your osteoblasts. You're making them begin to make bone, but it's not in response to muscle pull. It's not in response to strength. It's just you're stimulating them because this hormone is making them start building bone, and it's just being put down. I kind of like the example I liked in my own mind that I like to envision with this is again going back to engineering. Because if you're sitting in your house and you decide you want to make your house stronger, and you bring in a group of engineers to do that, what are they going to do? They're going to shore up your foundation. They're going to put more columns under your house. They're going to put some girders around the house. They're going to put brackets on the rafters in the roof to keep the roof from blowing off in the storm. They're going to structurally make your house stronger. So that's what hormones do. That's what Avista does. Now, what does Forteo or Prolia or Fosamax do? It's the guy who walks in with a bucket of plaster of Paris, takes a big scoop and slaps it on the wall, takes another scoop and slaps it on the wall. Now, does that make your house more dense? Yeah. You x-ray it, it's going to block x-ray beams because it's more dense. Is it going to make it stronger in the storm? No. And then what happens? The plaster of Paris crumbles off because there's nothing there to support it. So that's how I envision what these drugs do. They don't build physiologic bone. They basically make your bone, they make the DXA better because they make it more dense, but it's not structural. Whereas the hormones or the Vista, they're basically they're giving you something that as a postmenopausal woman you don't have. They're giving you the estrogen back so that your body starts acting like a premenopausal woman, not a postmenopausal woman.
Are there any downsides to a Vista?
There's a black box warning, so I feel really safe with it. I mean, at this point, I'm not prescribing it because, again, I've retired completely out of the medicine side. But what I would tell patients is that it increases the chance of stroke of blood clots, which is then stroke. Now, it doesn't bounce you higher than you ever were, but when you have estrogen in your body, you have a higher risk of blood clots. When you become postmenopausal, that risk goes down. So what the hormones and what the Vista does is brings you back up to where you were when you were premenopausal. It doesn't bulk you up. So that's why I felt safe with it. I think some ladies have reactions to it where they don't feel good with it, or there is some I think potential uterine hypertrophy. Now, tamoxifen is a sister medicine to Avista, and tamoxifen is used in breast cancer. Now, tamoxifen targets breast tissue and uterus tissue better than raloxifene or Avista does. So most oncologists will use tamoxifen. However, some oncologists prefer to use raloxifene or Avista because it has fewer side effects than tamoxifen. But if you have experience, if you want to look up those drugs, tamoxifen is also a SERM. It's a selective estrogen receptor modulator. So those are the side effects if you look it up. But I think it's the blood clots was the highest risk factor. But again, it's not raising you above where you were. It's bringing you up to the point where you were when you were premenopausal.
So would you choose a Vista or HRT? And I believe you cannot take them both.
You can't take them both. I would choose HRT. But if
HRT.
you either don't want to or you can't, there's a contraindication for it, then and the Vista is okay, then I would prescribe Vista in a heartbeat. Actually, another orthopedic surgeon taught me about that because I learned a Vista from the textbooks, and it says, well, if you have breast cancer, if you had breast cancer, then the Vista is the drug to choose to use, and that's what I was going by. But that doesn't necessarily make sense. So this orthopedic surgeon that's been practicing like 10 years older than me, more than I have, he doesn't do bone health, but whenever he fixed a broken hip, he put his patients on the Vista. All of them. They all went on the Vista. And he said that he didn't remember having to fix anybody's other hip after that. And his ladies didn't have problems with it. So that's anecdotal. It's one orthopedic surgeon, but he was doing it for about a decade. And as surgeons, you do things because they work, and it's you find what works for you, and that's what you do. So when he told me about that, I looked it up, and then yeah, this drug makes sense. So that's when I stopped using anything else, and I just if I was to prescribe a medicine, it would only be a Vista.
Okay. So we're at 8:59, and let me see if there's any. Oh, so um, is there any cutoff in age where you would not prescribe HRT?
No,
Okay.
if you're 90 years old and you're a woman, you're a woman. Your body needs estrogen.
Okay.
Yeah.
All right. So the final question to close out the night. If anyone here, if a woman could remember just one thing about DXA and REMS after tonight, what would you want that to be?
You're asking me?
Hmm.
That REMS measures is the structure of your bone, which is determines the strength, and strong bone doesn't break, weak bone breaks.
All right. If anyone has any questions in regards to the REMS events coming up, particularly here in Virginia, which I'm going to be hosting, please reach out to me. And I'm also this session has been recorded, and I'm going to send it out to everybody sometime tomorrow. So you will have the recording. And if you want to pass it on to somebody that couldn't be here tonight, feel free to do that. Dr. Bush, it has been an absolute pleasure. You are such an enormous wealth of knowledge, and to spend 2 hours with us this evening, it's just been invaluable. So I appreciate you willing to do this because this is such an important topic, and so many women are still so confused about DEXA and REMS, and I think that you cleared it all up for us. So I truly appreciate it.
Well, thank you for hosting us, Susan. This is, it's a pleasure working with you, and what you're doing is fantastic, and having webinars like this. And for a lot of ladies, if this is the first time you're hearing it, it's a lot of information. So really, if we have more of these, please tune in. And if you have questions, you can reach out to Susan. You can reach out to me. She'll have contact information for me. So please feel free to reach out. But again,
Hmm.
thank you for hosting this. This is wonderful. It was a lot of fun.
Yes, yes. Let me just see if I can. Um, I should think the REMS is in the chat. Um, Anyway, if you can't see the REMS event in the chat, I'll put it in the email tomorrow. So you'll have the information on the REMS events here in Virginia. And I'll also put the website for OsteoScan USA in the email as well. So anyone on the West Coast will have access to that as well. All right. Good night, everybody. And
Good
again,
night.
thank
Thank
you
you.
so much, Dr. Bush. It's
Okay.
been wonderful having you this
All
evening.
right, thank you. Yeah, you'll have a good night.
Okay, good night.